Good evening, everybody. Welcome to December's Cytokine Forum Live, Cytokine Signaling Forum Live. I'm John Isaacs. I'm from Newcastle University in the northeast of England, and I'm delighted to be here with my co-panel members, Hendrik from Munich and Rica from Berlin. So welcome to Hendrik and Rica. Have the next slide, please. These are all of our disclosures. I just wanted to welcome you all to the meeting this evening. Thank you for your support and for submitting questions prior to the meeting. Some housekeeping notes. So all of you will be on mute for the duration of the meeting. We've obviously had some questions from you as part of the registration, and when we've got those questions, but if you want to ask additional questions, which I hope you will, to any of the speakers, please submit those through the Q&A function specifically. There's also a chat box, but that's really for questions or if you're getting technical difficulties. So please don't submit your questions through the chat box because that will just confuse me and that's not a good place to be. So submit your questions through the Q&A. And I'd really encourage you to do that. So just an overview of the program this evening. So we're going to start off with some a short talk from Hendrik, and Hendrik's going to cover the topic of JAK inhibitor selectivity and the implications for therapy. We'll have a few questions at the end of Hendrik's talk, and then we'll move on to Rica, who's going to talk about JAK inhibition, the current results and the future perspective. And then we'll have some more discussion before we just show you a few slides about JAK inhibitors in clinical practice, their positioning in the treatment chain, and some initial thoughts, some very initial thoughts really about switching between JAK inhibitors and whether there's a rationale to that, and indeed whether there's any evidence that we should be doing that. And we'll all be discussing that before we have a final Q&A session for any further questions. But I emphasize, please do submit your questions in the Q&A because that's really useful to us to be able to interact with you. Okay, so without further ado, I'm going to introduce Hendrik. So Hendrik Schultzkopf is, as I've said, he's from, Hendrik works in Munich. He received his Doctorate of Medicine from the University of Hamburg in Germany in 1988 for his work on the arthritogenic factors of Yersinia. He was promoted to Professor of Clinical Immunology at the University of Erlangen-Nuremberg in 2006, and since then has held the position of Professor of Internal Medicine and Rheumatology at Munich University Hospital. And he's got nearly 30 years of experience in the field of clinical immunology, and Hendrik is one of the foremost authorities in the inflammatory arthritides and the mechanisms behind those diseases. His current research focuses on cellular and molecular pathogenesis of autoimmune diseases, and he's currently leading research into mechanisms of sustained autoimmune T-cell activity in diseases such as rheumatoid arthritis, with the two important aspects of increased activity of effector T-cells and reduced functionality of regulatory T-cells. So without further ado, Hendrik, the floor is yours. We're looking forward to your presentation.
John, thank you very much. And hello to Rica, hello to John, and thank you very much for having me tonight. When you get introduced, like if it is that you have worked for more than 30 years, you get the feeling that you're getting old. Thank you for this, John. But we have had good friendship for over the time. So what I'm going to talk to you briefly about is one of the main topics that is associated with JAK inhibitor at therapeutic mechanisms. One is the selectivity, and really does that have an implication for therapy? The other one is safety, because you're all aware that there was a safety study just recently announced by Pfizer for long-term follow-up of at-risk patients that created some really trouble in the JAK community. But I'm going to talk about JAK inhibitor selectivity, and I want to just introduce the topic, what is selectivity all about, and then coming transferring selectivity of a JAK inhibitor into real life, into the clinic as a mechanism of therapy for inflammatory disease. This is the idea that we have understood that rheumatoid arthritis is a disease that is dependent on not only cells, but also the interaction of these cells. And within the interaction of these cells, we can now nicely inhibit these cells directly, or the mechanisms that they use in order to inform another cell for what they actually have intended to do in order to, for example, orchestrate an immune response. And this is what we do with biologics. So these monoclonal antibodies that directly target cells or cytokines. Now, we have also understood that the cytokine signal inside the intended target cell by virtue of binding to its receptor, then the receptor has a signaling cascade followed upon the binding of the cytokine to the cytokine receptor, and eventually one of the terminal molecules within the signaling cascade gets phosphorylated. Well, this goes by itself. It gets phosphorylated, and by phosphorylation, it gets an entry signal into the nucleus where it can then start gene transcription. And if we were to not only not to neutralize the cytokine themselves, but to prevent the phosphorylation process induced upon binding of the cytokine to the cytokine receptor, we might as well interfere with the signaling of the cytokine. These signaling cascades are ubiquitously used in biology. One of the most important signaling cascade in inflammation is the JAK signaling cascade, where two molecules, usually two, in a rare circumstance, three molecules on the outside of the surface bind the cytokine. They get in close proximity, which induces phosphorylation of a molecule called Janus kinase, or JAK. The JAK phosphorylates STAT, which is signal transducer and activator of transcription. So that's a transcription factor, which then becomes phosphorylated and then induces gene transcription. So that is important in many signaling events in the immune system, in the blood system, and therefore it's of most important in order to potentially prevent signaling from one blood cell to the other, including white blood cells, leukocytes, and lymphocytes. There are four members of the JAK family kinase, termed TYK2, which was actually the first one identified, and then JAK1 through 3. And they have different functions, all in different and selected molecules. JAK1, cells. JAK1 binds to the type 1 cytokine receptors. It transfers signaling through the common gamma chain cytokines, so the T cell cytokines, IL-2, 4, 7, the 9, 13, 15, and 21. It also transfers signaling through the interferon type 1 receptor, the interferon type 2 receptor, the GP130 receptor family, and therefore it's involved in IL-6 signaling, and finally the IL-10 receptor family. So ubiquitously expressed on white blood cells, where it can, on different cells, where it can then transfer signaling from different cytokines. If you knock out JAK1, you figure that this is something that you had not experienced before, or even thought of, because it's lethal in neonatal mice just after birth, because these mice apparently have a difficulty in suckling, meaning that JAK1 is not only involved in transferring signal transduction in inflammation, but also in other areas of the homeostasis of the body. JAK2 is the prominent JAK, which is involved in growth of many of the hematopoietic cells. It transfers signaling through the common beta chain cytokines like IL-3, 5, and GM-CSF. It also confers signaling through the type 1 and 2 receptor, the GP130 receptor, and it's the and one most important single JAK that transfers the erythropoietin information into the cell. And therefore, if you had knocked out JAK2, that would result in a situation which is embryonically lethal at day 12, simply because there's no growth of hematopoietic cells. JAK3 is interesting because it's expressed in hematopoietic cells. It does occur in T cells, in NK cells, but also monocytes, and it transfers signaling through the IL-2, 4, 7, 9, 13, 15, and 21 cytokines, the common beta chain. If you knocked out JAK3, the phenotype is vital, but it is a SCID situation where there is no way that the T cells and B cells can interact with each other or even transform. Finally, TYK2 was, as I said, the first described JAK family member. It's important for IL-10 receptor signaling, type 1 interferon receptor signaling, GP130, the P40 of the IL-12 and IL-23 complex, and the IL-4 receptor alpha, which is involved in IL-4 and IL-13 signaling. Of interest for rheumatologists, if you knock out TYK2, the animals will become resistant against collagen-induced arthritis, and they also become resistant against LPS-induced inflammation. So that makes TYK2 a probable target for systemic inflammatory responses. So JAK signaling pathways work in essence like this. There's cytokine receptors on the transmembrane cytokine receptors bound to a JAK, 1, 2, 3, or TYK2. By being approached by a ligand, this ligand interacts with one of the receptors that dimerizes with the other chain, bringing into close proximity the two JAKs, which phosphorylate each other or the receptor themselves. And what you can see here, they use for phosphorylation, of course, ATP, where they transfer the terminal phosphate group onto the target, which in this case could be JAK itself, the JAK on the other side of the on the other receptor chain, or on the STAT molecule. And this is important for understanding because all what kinases do, they transfer the terminal phosphate group from ATP, and therefore all what JAK inhibitors should need to do, they should prevent this ability to transfer the phosphate group from ATP. So by getting close in appearance to ATP, they may directly prevent the activity of a Janus kinase by sitting in the enzymatic pocket and preventing ATP from becoming a donor of ATP. So once these JAKs are phosphorylated, they recruit STATs, they phosphorylate STATs, indicated in red here. The STATs molecule dimerize, and then, as I said, they enter the nucleus and induce transcription of inflammatory cytokines. Many of the cytokines that we have all worked on over the last 30 years or so that are important in different rheumatic diseases, in particular rheumatoid arthritis, they use the JAK-STAT system in order to transmit their signal, and they are shown here in the upper part. These are important cytokines, for example, IL-6, for example, IL-12, for example, IL-23, GM-CSF, interferon. So many of the cytokines involved in active inflammatory responses signal through the JAK-STAT kinase. So that JAK-STAT kinase pathways. So that makes the JAK-STAT signaling pathway an interesting target for interfering. And what can be seen here is that the different receptors in light green in the membrane, they are shown as if these are two different chains, and they pair, and on the inside of these two different chains are different JAK molecules, which is they are bound to their particular receptors. So in other words, if these two receptor chains get in close proximity, once they have bound their cytokine, the two different the two JAKs that get in close proximity, they are usually heterodimeric, so different in nature. There's one single important exception for this, which is the JAK2 homodimer, as shown here, which is involved in the transferring signaling through all the growth factors of the hematopoietic lineages. But all other pro-inflammatory cytokines, they use heterodimers. One IL-6 even uses a heterotrimer, and there's no such thing like a JAK1 homodimer, a JAK3 homodimer, or a TYK2 homodimers. So in summarizing this part of the talk, cytokines use different JAK combinations. As I said, they use different cytokine JAK combinations. The only expressed hematopoietic JAK is the JAK3, and it's always present in combination with JAK1. In other words, there's no such thing as a JAK3 homodimer, and selectivity for one of the other, JAK1 or JAK3, will always inhibit the function of the dimer, of the heterodimer, because that's always a heterodimer between JAK1 and 3. JAK1, 2, and TYK2 are ubiquitously expressed in different cells. And this is a finding now for the final part, what is the implication for therapy. Now, what can you do in order to identify, define, and characterize a JAK inhibitor? These are the 5 JAK inhibitors which are currently licensed somewhere in the world for the treatment of rheumatic diseases. It's upadacitinib, baricitinib, filgotinib, and tofacitinib, licensed in the US and in Europe, and peficitinib in Japan. And what can you see here is that they are associated with particular JAK numbers, and this is taken from in vitro assays where these molecules are able to inhibit the signaling through a particular JAK phosphorylation process in an in vitro cell culture or even complete in vitro system. And therefore, people have identified upadacitinib as a preferentially JAK1 inhibitor, baricitinib as a JAK1/2 inhibitor, filgotinib JAK1, and tofacitinib a PAN inhibitor. What does it mean? Well, Ernest Choi has shown a wonderful data set some years ago where he has actually looked at the ability of the different Janus kinases to inhibit 50% of signaling mediated through JAK1, 2, 3, and TYK2. And what you can see here, that tofacitinib, so the pan-JAK inhibitor, has about the same nanomolar concentration required in order to inhibit 50% of the activity mediated through JAK1, 2, and 3, not so TYK2. However, baricitinib, a JAK1 and 2 inhibitor, has about the same low nanomolar concentration required for inhibiting 50% of signaling through JAK1 and 2, but about at least 100-fold higher for JAK3. So that is the reason, the background why baricitinib is called a JAK1/2 inhibitor, tofacitinib 1, 2, 3, filgotinib 1 if you compare it with JAK2, upadacitinib 1 if you compare it with JAK2 and 3, and peficitinib probably 1, 2, 3. So this is by in vitro assays, and Ernest has this is a wonderful paper that he published. So what does that mean now for clinical practice? Well, selectivity means at one point, first, that a certain concentration of a JAK inhibitor, one JAK isoform can inhibit one JAK isoform better than another. So if you increase the concentration, it may very well be that the JAK1 specific inhibitor will all of a sudden inhibit JAK2, JAK3, or even TYK2, simply because concentration is high. The selectivity, therefore, is dose dependent. Especially at higher concentrations of the inhibitor, there's a potential to influence other JAK isoform, and that's easy to understand because simply all what JAK inhibitors do, they mimic ATP, and we have 527 genes for kinases in our body. Given that we only have 27,000, this is a huge bunch of similar molecules. They all transfer ATP from phosphate from ATP. And there's no real possibility to mimic ATP in one particular situation better or specifically and not have an ability to bind to one of the other 527 kinases. So it's always a concentration dependent thing. But the important thing is that no JAK inhibitor inhibits one JAK isoform only. That's only preferential inhibition at a given dose. And in clinical development, however, an attempt is now made to find the optimal dose at which the highest possible efficacy is achieved with the lowest possible toxicity. That is to inhibit only the desired kinase. That's a huge target. But what I mean with this is nicely illustrated here by a study with upadacitinib, so a JAK1 inhibitor. JAK1 is inflammatory, and it should not have an effect on JAK2, which is a hematopoietic growth factor. And what can be nicely seen on this curve is that by increasing the concentration of upadacitinib, there's a nicely associated increase of effectivity of upadacitinib, as shown here with percentage of patients acquiring ACR 50. However, there's a threshold here at 50 milligram, which is not exceeded at 30 milligram. If you were looking now in the very same patients for the hemoglobin levels, all of a sudden, the shift in hemoglobin only starts at later situation when JAK2 is probably inhibited. So this is a negative impact here. It's only shown for reasons to show this better, that at higher concentrations, all of a sudden upadacitinib may have an effect on JAK2, which is shown here as a negative effect on the recovery of hemoglobin. And very similar, a thing that we published some years ago with tofacitinib, just remember, a 1, 2, 3 inhibitor, where we have looked at different dosages, 5 milligrams and 10 milligrams twice a day as compared to adalimumab, and we could nicely show that the hemoglobin in these individuals was highest in the tofacitinib 5 milligram BID, probably because the inflammation was controlled and therefore resulting in hemoglobin increase. But if you had increased tofacitinib to twice 10 milligrams a day, all of a sudden this increase was lower, probably because tofacitinib at 10 milligrams twice a day directly inhibited already JAK2. So in other words, it really is a dose-dependent situation, how selective a JAK inhibitor, at least the ones that we have at this moment, may be. And finally, we have to remember that the JAKs are always pairs, and they're with the exception of JAK2, they are heterogeneous, they're heterolog pairs. There's no homodimer, they're heterodimers, meaning that JAK1 and JAK3 are associated with the common gamma chain situations, and JAK1 and JAK2 with interference and so on. So if you were to inhibit JAK1, you would be able to inhibit the first 4 dimers which are shown here. So this one, this one, this one, and this one. You would not have any effect on the JAK2 and JAK2 homodimer, and certainly no effect on the JAK2 homodimer. But if you were blocking the JAK2 inhibitor, the JAK2, all of a sudden you had the very same effect on the GP130 associated heterotrimer. You would have an effect on the interference, and you would have an effect on the JAK2 heterodimer as well as on the homodimer. If you were blocking JAK3, you would also have the very same effect as if you had blocked JAK1 in the situation of a T cell signaling. In other words, JAK1 and JAK3 inhibition may give you the very same functional outcome in terms of blocking T cell cytokines, and there's no necessity to have this even more specific because the partner is JAK1, or the other way, the partner is JAK3, if you had a less selective or highly selective JAK3 or JAK1 inhibitor, respectively. And finally, the TYK inhibitors will also give you a different appearance. So if we are going to summarize, the Janus kinases JAK1, 2, and 3, and TYK2, they always act in homo or heterologous pairs and activate transcription via 7 different steps. There was no time to go into this in any detail. And the only homologous pair is the JAK2 pair associated with the growth cytokines in hematopoietic cells. Important to understand for the principle is that selectivity of JAK inhibitors is relative and it's dose dependent. There's no such thing as a complete blockage of one JAK and without interfering with any of the others. The selectivity, which is measured in vitro, as shown by Ernest, for different JAK isoforms can only be projected to the clinical effects of JAK inhibitors to a limited extent, in part due to the fact that they usually function in heterodimers. The current data indicate that pan-JAK inhibitors and moderately selective JAK inhibitors are comparably effective in rheumatoid arthritis, and they also have a very similar safety profile. Also, again, arguing that it doesn't matter whether you have a fully specific or a completely unspecific JAK inhibitor. And finally, my last word is the concept of JAK selectivity is based on in vitro assays, with very limited impact on cellular and even less clinical aspects of the use of JAK inhibitors. With this said, I thank you very much for your attention, and I hope I have provided the stage for the discussion.
Thank you very much, Hendrik. That was excellent. And thank you very much for doing that. I should have mentioned at the beginning, but Hendrik's not been feeling great following a COVID vaccine yesterday. So really appreciate you joining us this evening. Please put your questions in the chat. Whilst we await your questions, I'm going to ask you a question, Hendrik. You stated very clearly that selectivity is based very much on in vitro data, and we don't know for certain how well that translates to the clinic. I suppose one question that I'm often thinking myself is, if you did have perfect selectivity, which JAKs would you want to block? Because I'm not convinced I know in my own mind which of those 6 or 7 pathways is the one that's going to give me the best efficacy. Would you like to speculate?
I think this is very much mirrored by the clinical experience we have with the different JAK inhibitors. It really doesn't matter what, as long as you inhibit many of these cytokines. Well, if you gave me the choice to inhibit just one, I think with JAK1 you would be able to block inflammatory activity as well as JAK3 mediated T cell cytokine inhibitor. Certainly, I would not in rheumatology inhibit JAK2. From the preclinical data, TYK2 is a wonderful target. From the clinical data that we have so far, it didn't appear to be as promising as we had thought, maybe simply because the disease that we had treated were not the ones that are most susceptible. I think I would either go for JAK1 or JAK3, probably JAK1.
Okay.
But yeah, you're completely right. Maybe we don't want a perfect selectivity. If we had there's one thought that the JAKs at the inside of the cell actually may become differentially affected by different JAK inhibitors, and therefore the different JAK inhibitors may have different effects, even if they have the same target. And so that's something that's in the understand in the research at this moment. But
right. Thank you. There's a questions come in actually into the chat rather than the Q&A, but I can still see it, so that's great. It's from Rodolfo Pera, and he's saying, is there any explanation related to the thrombotic events which are seen with JAK inhibitors, and is this related to selectivity and dose dependency?
I think this is the $2 billion question. If Gilead and Lilly and AbbVie would have the solution, say, okay, all which has been shown with the tofacitinib is related to a particular effect of tofacitinib, rather being a pan-JAK inhibitor, they would be fine off here. But at this moment, we can't really say. We don't know the molecular events behind this. We don't know the molecular events behind the oral surveillance 1133 study showing us increased mortality or increased MACE and increased, well, I should say increased MACE and increased malignancies. We don't know. And so the question is absolutely correct. And I should say, as long as we don't know the molecular mechanisms involved contributing to one of these side effects, we should probably not be so brave in saying it's just associated with one particular JAK inhibitor, simply because we don't know.
Thank you. I mean, out of interest, in your opinion, and I guess it is an opinion, do you think that's a robust signal these days? Do you think we can say that one or other of the JAK inhibitors is definitely associated with thromboembolic events?
Well, robust is very relative here. It's very low numbers with very low frequencies. And I remember well when we had the very first data from one of the ACR meetings with baricitinib, I was involved in looking at all the tofacitinib data that were published at that time, the JAK3, the phase 3 clinical trials and so on. And there was no signal at that point for tofacitinib. Now we have the opposite, or we have signals there. So I think it's not a robust signal. It's a signal that we do see. It's not as robust as tuberculosis activation in TNF inhibitors, if not prevented. It's a signal that we have to keep in mind, but we don't understand that, and it's not something that should necessarily prevent us from using this wonderful family of inhibitors if we pay attention to the population at risk.
I agree. Thank you. Just before we move on, I'm going to ask you one other question. If Rica has a question, there'll also be time. But as you mentioned at the beginning of your talk, the knockouts are lethal, and several of the knockouts are lethal. How do we manage to develop drugs which are so relatively safe in that context?
Yeah, this is also a wonderful question. I think the answer is a hypothetical answer. That is, we are not knocking out with whatever JAK inhibitor we try. We are not completely preventing forever signaling through that JAK. We all know that we have to give the JAKs once a day or even twice a day because they have such a short half-life. And if you looked at the pharmacodynamics, then the activity of these JAKs is back within hours. And therefore, I think that prevents the lethal phenotype, the appearance of something that we see from the lethal phenotype in the complete knockouts.
Great. Okay. If there's no other questions, Hendrik, thank you very much for that. I think we should probably move on in the interest of time. So it's now my pleasure to introduce a good friend, Rica Alton. So Rica is head of the Department of Internal Medicine, Rheumatology, Clinical Immunology and Osteology at the Schloss Park Clinic, University of Medicine Berlin, where she also serves as director of the Rheumatology Research Center. She's a member of the Global Alliance for Patient Access and participates in the OMRAC Steering Committee Rheumatoid Arthritis Flare Group. She studied medicine at the Free University of Berlin, where she also trained in internal medicine and rheumatology. Following this, she studied immunology at the Institute of Immunology at the University of Zurich. Her research interests are focused on the development and systemic evaluation of biological and immunomodulatory treatments for rheumatic diseases. So who better to come and talk to us this evening on JAK inhibition, the current results and the future perspectives. Rica, the floor is yours. Thank you.
John, thank you very much for this kind introduction. Yes, tonight I want to share with you some insights, like snapshots. Can we move forward to the next slide, please? So this is the famous jackpot study, and there was an update also at this ACR. This is a little bit former data, which were published by Kim Lauper. And here you can see that the adjusted overall JAK inhibitor retention tended to be higher for JAK inhibitors than for TNF, with large variation, of course, between the different countries. But in the 5 big EU countries, there's really a high retention rate for the JAK inhibitors compared to the TNF. And we are seeing more and more updates on this. Especially, I like very much personally the data from the Swiss Quality Management Registry, because they put together very nicely what we can import in our daily clinical practice. Next slide, please. So moving on, I brought some information for you on the different JAK inhibitors. We have covered already the so-called selectivity, which is mostly, of course, also promoted by the companies. Upadacitinib is the so-called JAK1 inhibitor, but there are very good data on UPA. UPA monotherapy was superior to methotrexate across multiple measures of clinical response and disease states in those patients who were methotrexate naive or non-responders. And you can see a very good benefit. All in the whole program, Select Early and monotherapy, all are tendency to the right for the 15 milligram therapy, which is the standard and in-label therapy now. Next slide. So the risk, which is already addressed here, except for herpes zoster, all safety events in the short-term risk analysis occurred are at similar incident risk like in the normal RA population. So there were no differences for the monotherapy versus MTX or UPA plus MTX versus adalimumab, the comparator, plus MTX. And this is so important that we see from the very beginning, especially this risk for herpes zoster, because at least in Germany, we are in the very fortunate situation now that we can offer a vaccination at the point where we decided to put a patient on a small molecule, and then we can do the second shot later. And this is highly appreciated by the patient because it's fully reimbursed now, and that is a good offer. I know that this is not the case in all countries, especially in Asia, where the incidence rate for herpes zoster is much higher. There are more problems with reimbursement, unfortunately, for this problem. But I think in Germany, for instance, we can manage it nicely. And in our daily clinical practice, we have seen, of course, some herpes zoster cases, but most of them were more mild than complicated, and only for one segment, not multi-segmental, and they were all nicely treated. So we have not seen really severe complications of herpes zoster in our population, treated with all small molecules, not only with one. Next slide, please. So filgotinib, that was the last companion in the group, also a specifically JAK1, so SAD inhibitor. Next slide, please. And the data are also very good. There are many data collected by now on the safety and efficacy of filgotinib up to 4-year result. There was published in an open label extension study of the phase 2A RI program. And we also participated in this program in our trial unit. And now FIL is approved in Europe and Japan for the treatment of rheumatoid arthritis. And it will still be under investigation for other chronic inflammatory diseases. And in the last 4 weeks, I think it has got already another approval for the AxSpA group of patients. So that is also a new information for this group of patients. Next slide, please. So you can see here the efficacy. They were nicely met in the ACR 2050 responses among patients remaining in the study maintained throughout the 4 years. And that is quite a bit, 4 years on filgotinib already, because they started early and then it took a little time to get the approval. So it's very good that we have this reassuring 4 years data. Let's move on. So the adverse events, they are in the same field as we have seen before. The safety profile was consistent. And there was also shown a sustained efficacy for filgotinib when administered at 200 milligrams daily, either alone or also in combination with methotrexate. So we have seen no specific signal over time in these patient group treated with filgotinib, while there was a very good efficacy. Next, please. So the so-called bad guy at the moment, I think it is not right to call it the bad guy. Tofacitinib was the very first one. It was first approved in Switzerland and in the US. It took a while until we got it in Europe. Next slide, please. And we have really the longest data, which we have already for tofacitinib. And we have here the overall maintenance or drug survival or retention rate with or without concomitant methotrexate. And you can see here also that there was very good results over time. Can we move forward, please? So my specific interests are the patient-reported outcome. And we did a post-hoc analysis together with other colleagues. And what we found is that especially there is strong correlation between the patient's global and pain, physical function, and fatigue, of course, in rheumatoid arthritis. And we analyzed 3 trials of tofacitinib. And in these trials, we found out, can we move forward to the next slide? That especially, just can we go back again? Sorry, it was a little bit rapid. That pain was really the essential driver for the patient's global. And the patient's global, of course, is moving always to disease activity. And we have to take this more and more into account when we analyze disease activity, that disease activity is mostly driven by pain. And sometimes, as we know now, this pain really has a disconnect from the inflammation. So maybe we are misled by disease activity, by the wrong interpretation of the patient's global for disease activity. Next, please. Now we come to the so-called bad guy. Is tofacitinib, MACE, and the malignancies a cause for concern? Everybody is talking about this. We have not seen the full publication. There have been, of course, some abstracts and oral presentation at this year's ACR. For me, oral surveillance has some major weaknesses. There are so many open questions that at the moment, I'm not able to draw really a clear conclusion out of the data I have seen so far. Of course, these decisions by the FDA will have an impact also on the whole class, on the other small molecules, I think. But nevertheless, we have to wait at the moment, and we don't have to be impatient. We have to wait for the demographics of those patients who were included, whether it was okay to use TNF inhibitors as a comparator group, whether that was already maybe a weakness of this study. So really, it might be a cause for concern. Hopefully, if we really do take a good history in our patients and really exclude those patients which have a bunch of risk factors also already for VTEs and pulmonary embolism and also cardiovascular risk factors, then I think we could travel on the safe side, doing giving these very good drugs to our patients, because the patients really, they have a rapid pain relief. And we are coming just to the next slide, I think, for the pain. Baricitinib has worked a lot on pain, and let's move forward. We also have seen a lot, and pain is very important, as we have seen here by the arthritis power study, which was recently published. And fatigue and pain are the most important patient-reported outcome. And when the patients are treated in a rather short disease duration with a small molecule already, they really experience that their pain is changing. When the pain is a long-standing pain for years and years, and many of these patient population in these phase 3 randomized clinical trials have a disease duration over 10 years, then the story is different. Next slide, please. So what we have heard before, but I can repeat it not as often as necessary, pain is really the greatest contributor to the patient perceptions of the disease activity. So, and there is a disconnect for the patients and for the physicians. We still, and we have learned this so highly appreciated in our OMRAC FLAIR group, for the physicians in all our surveys, we found that the swollen joint count is the greatest contributor to perception of disease activity for the physicians, but not for the patients. For patients, pain is the most important factor. Let's move forward. So a lot of research have to be done there. And is it inflammatory pain? Is this neuropathic pain? And I think more research done by MRI, especially by functional MRI, will give us the pathway to better understand the nature of the pain in our patients, and then we can address it in a more proper way. Next slide, please. So there are many mechanisms, especially for the nociceptive pain. And nociceptors, of course, we know are warnings about changes in the homeostatic. As in other chronic diseases, the pain associated with the rheumatoid arthritis is very complex, multifactorial, and not fully understood. There is a lot of research on the agenda to do. Next slide, please. So the cytokines, and there we come back to our point, mediate the pain of rheumatoid arthritis in the following locations: approaches that can normalize the threshold for activation of nociceptors or diminish central transmission would be desirable for patients with rheumatoid arthritis. And I think we are nearly at the end now. Yes, that is the change in the pain VAS scores at week 24. And these are the data we can see for baricitinib, and especially here for the baricitinib 4 milligram arm, the data were very much superior to the comparison group that are data from the BEAM study, where the data were compared with adalimumab and methotrexate. Next slide, please. And also all patient-reported outcomes from the very beginning have been changed significantly, especially also morning stiffness, and also the tiredness has been observed with a rapid reduction in the BARI group in the BEAM study for the first time, but also shown in all the other trials, and also the real-world observational data. We have just published real-world data and shown these in the BE-REAL study at the ACR, and the same is true there for also the real-world patients, which also have, interestingly, a longer adherence to the treatment compared to those patient group who were treated with biological DMARDs or other TS DMARDs. Next slide, please. So I can summarize. We have many new drugs got in the last years at our hands. Of course, we know about the different selectivity and the different signaling profiles. Whether that matters in clinical practice so much, I doubt. Despite showing similar clinical efficacy, the reported incidence rates of some adverse events of special interest vary among the different JAKs, but we have to know these and take it into account. Especially, we have also to take into account whether in which endemic region we are living. Certain JAK inhibitors may be more appropriate for certain patient subpopulations. This we have to know when we are really going to the prescription. And the initiation of JAK inhibitors and the individualized treatment target should be based on a shared decision with the patient in the end. Thank you very much for your attention. I'm really happy to ask your questions and answer your questions.
Thank you, Rica. Thank you very much. Brilliant exposition. There's one question in the Q&A at the moment. Please do send your questions in. This one, you've kind of partly addressed it, but I'm going to ask it anyway. It's from Edgar Stemler. And Edgar says, provided the multi-cytokine related concept of JAK inhibition is not only effective in reducing inflammation, could it be an explanation of the slightly improved pain alleviation as demonstrated for baricitinib and upadacitinib as compared to adalimumab? So in other words, is there any more to it? Is it all to do with multi-cytokine inhibition, do you think? The pain
Actually, it's a very interesting thesis, at least. It's interesting to investigate on this, because clearly it has been shown, and for me, for first time, very astonishingly in the BEAM study, published by Peter Taylor, how the difference was seen rapidly between baricitinib and the patients which were randomized to the adalimumab group. So there might be an additional mechanism of pain relief by the small molecules, maybe due to more suppression of IL-6, which might be an explanation. And we did not much investigate also the brain relationship between the hypothalamic axis. And that also might play a role in the pain reduction. This is much to do research to answer this complicated question, I think.
Okay, thank you. There's a comment here from Massimo Gadino, which I'll read out, and I'd be interested in your perspective. Again, it goes back to the oral surveillance study. The preliminary findings stated a hazard ratio of 1.33 for adjudicated MACE, with 95% confidence intervals between 0.91 and 1.94. The hazard ratio confidence interval crossed 1 for MACE and crossed the pre-specified non-inferiority margin of 1.8 for both MACE and malignancies. In my opinion, we cannot say whether tofacitinib has clinically significant inferior safety profiles in cardiovascular and malignancy risk compared to TNF inhibitors.
I think he's right. I don't have the figures really in front of me now, but that is what I tried to say was inconclusive for me at the moment. I think we are not allowed to draw these conclusions. Hendrik, what do you think?
But the entire study was not designed to show that tofacitinib is inferior. It was designed to show that tofacitinib is non-inferior to adalimumab, and because the result crossed the 1.8 predefined margin, we cannot say this. The other word, I completely agree with you, Rica. The question may be completely right. We should not say that tofacitinib is inferior. All we can say from the study that the study has shown that tofacitinib is not non-inferior. And you figure out what that difference is. But the words are clear. It's not non-inferior. It's not inferior, which we cannot say. And I completely agree. We have to understand the entire data. We have to understand the subsets. We have to understand all the post-hoc analysis. I'm looking forward to the main paper. I'm an author on a different paper within the 1133 consortium, which finished. We just wait for the main paper to be presented, and I think that will hopefully enlighten a few of the questions that we all have. At this point, I would think there's no way but to interpret the data as they are interpreted by the FDA, meaning cautiously, in order to not ignore data that we can also not, by scientific reasons, ignore. And therefore, it's a situation where I completely agree with you. It's not sound, but the data are there, and we should take this as a very, very cautious recommendation to deal with our patients at this moment.
And Massimo's just added the number of subjects was relatively small.
That's correct.
That's absolutely right.
The number needed to harm is enormous, yeah. But we are not talking about harming. We are talking about yeah. So that's something we all need to actually. I think this is the major issue of JAK inhibitors this year, and it will take a year, 2 or 3, in order to understand the entire study. If we eventually will be able to understand exactly what's going on. And there will be differences in interpreting MACE and malignancies. I mean, for MACE, it could be very easy to say, okay, the problem is that the TNF inhibitors are just preventing MACE, and therefore tofacitinib is not bad, but it's neutral, whereas the TNF inhibitors are good. But this is difficult to use the same argument for malignancies. So we have to see.
Yeah. It's also very ironic, Hendrik, given how many years we were told not to use TNF inhibitors in patients with a history of malignancy, which I always thought was a bit weird, to be honest. So, it just shows you how the times can change. Anyway, look, thank you for your questions in the chat. I guess we should move on. There'll be time for more questions at the end, so keep sending them across. We're now just very, very briefly, just got a few slides on JAK inhibitors in practice. So I'm going to start with the EULAR-RA management recommendations, and I'm sure you're familiar with these, but these are stage 2 and stage 3. So if you remember, stage 1 is conventional synthetic DMARDs. If you fail conventional synthetic DMARDs, then EULAR guidelines suggest either add a biologic DMARD or a JAK inhibitor. So there's no preference there, but you could start with either, failing conventional synthetic DMARDs with either a biologic or a JAK inhibitor. And similarly, if you then fail on that step, you can either change to a second biological DMARD or at that stage go to a JAK inhibitor. So basically the message here, you can either start your sort of advanced therapies with a JAK inhibitor or use them second line after failing a biologic. And there's nothing here about cycling, of course, at the moment, cycling, changing from one JAK inhibitor to another. Just a few slides in terms of where you should start. So this is upadacitinib, select compare therapy following methotrexate failure. And this simply shows that actually in purple here is adalimumab, in orange is placebo with background methotrexate, and green is UPA plus methotrexate. So all three arms have methotrexate. And you can see actually from a very early time point, from 2 weeks probably, that UPA is superior, statistically superior to adalimumab in terms of DAS28 low disease activity. And similarly, on the right-hand side, quality of life in terms of SF36, physical component score, fatigue, and morning stiffness. So this is not true for all the JAK inhibitors, but certainly for some of them, there is superiority to adalimumab. And in this trial, for example, there are ranked endpoints showing that this was a statistically significant superiority. This is RA beam. So this is now baricitinib. And if you look at the patients who are in remission or low disease activity at 24 weeks, baricitinib had showed a greater improvement in HAQ-DI than with either placebo or adalimumab. So again, a slightly more complicated outcome, but again, showing some superiority for baricitinib over adalimumab in this particular outcome, HAQ-DI in this particular outcome group, so remission or low disease activity. This is RA beam. And again, similarly, this is fatigue by remission status. And what we're really showing here, actually, this is important for patients because even for patients in remission or low disease activity, there is still fatigue in several of these patients. It's slightly less. Remember, with fatigue, upwards is good, so almost counterintuitive. So there's slightly less fatigue with baricitinib than with adalimumab or placebo, but nonetheless, fatigue is still there. And in fact, fatigue is pretty much the same across patients who are in remission or not in remission. So there is still a lot of unmet need around fatigue in rheumatoid arthritis patients, even with these very good therapies. And this is a JAKpot, again, the JAKpot trial, which Rica started off with. So this is actually looking at cycling JAK inhibitors. So, I think when anti-TNFs came out, probably, I hate to think how long ago now, probably 20, 30 years ago, we didn't think cycling anti-TNFs would work. We now know that it can do, although there's a little bit of a biologic explanation in terms, for example, of anti-drug antibodies might partly explain that. But this jackpot study, here you can see patients who have switched from a JAK to a biologic DMARD in green and from a JAK inhibitor to a JAK inhibitor in orange. And actually, if anything, there's slightly better drug survival with the JAK to JAK switching, although statistically there's no difference here. And similarly, the change in DAS28 shows no difference. So perhaps a little bit counterintuitive that you can switch from JAK to JAK and see as good an outcome as switching to a completely different class of drug. And we'll come back to that in the discussion. So that was just a really, really quick few slides just to pop some ideas into your thoughts. And again, if you do send some questions in the Q&A, and we'll address those. I mean, that jackpot study, Hendrik and Rica, in a funny sort of way, that was coming back to my first question to Hendrik about which pathway would you choose in terms of efficacy? Because I guess if the JAK inhibitors work through different JAK pathways, if one might inhibit IL-6 more than interferons, and for example, another one might inhibit GM-CSF even, maybe you would expect switching to work because these are not all the same in the same way as TNF inhibitors are all the same, assuming you believe in the selectivity principle. Is that fair?
I think that's fair. The problem with GM-CSF, you can't get it without EPO, and you can't get it without thrombopoietin. So that would have an effect not only with leukocytes, which I must admit, if I had been asked to put all my whatever I had on a bet whether GM-CSF inhibition would work so well in rheumatoid arthritis, I would have always said no. I cannot really see that. But now we have to once again to realize that GM-CSF is a valuable target, but I think not via JAK2 inhibition, because as I said, JAK2 will also be inhibiting. JAK2 inhibition will also affect hemoglobin and thrombosis, growth of thrombocytes.
Rica, any thoughts on the switching, why it might work?
Actually, there are always rumors, and everybody of us has personal experiences. There also the shared decision comes very much in. If you have experienced a JAK inhibitor and the patient is not sufficiently controlled and is not happy with this treatment, first of all, we have to ask the patients, are you going to move on with a similar treatment? And actually, there are many possibilities of answers. I have around, let me say, around 20 switches, which I did in my own experience. And 50% went well and 50% did not work. So that is not a good summary. And the reports on the ACR and also at the EULAR are rare. There are no big databases so far. They all from Turkey around 50 or from another country around 100. So we can't really deduce any conclusions out of these small numbers. So I think it's worthwhile. I think if there are reasons for taking an oral medication, there are patients who only want oral medications, then I think it's worth a try. But otherwise, I would also go to another mechanism of action.
But I think, Rica, the main difference between what we now see in the different abstracts and the experience that we all have is that the experience that we have was on patients who we put on JAK inhibitors eventually after they had failed all the others, simply because the JAK inhibitors were the most recent addition to our treatment armamentarium. And in these situations, we all know that treatment is difficult and switching is difficult simply because these patients appear to have a refractory disease. And it may be, if you had now, as John has shown, following the EULAR guidelines, that you can actually start with a JAK inhibitor, you would probably have much better efficacy if you were going to switch the early guys. I think at least this is what I tend to say to myself if I'm trying to convince a patient to switch a JAK inhibitor to another, that despite my own not so good experience, I think it may be worth, if that patient is one who has started with a JAK inhibitor rather than being at the end of failing 5 or 10 biologics.
Yes.
Yeah. Thank you, Hendrik. I mean, are you tending to use JAKs as your first advanced therapy these days, or do you still start with an anti-TNF, or does it vary from patient to patient?
We have, first of all, after methotrexate, I started discussion with the patients. And actually, many patients really, and if you really guide this discussion in an open way with an open question and open ending, many patients decide really for the oral medication for a small molecule. So we are much earlier in the treatment line.
But you have all the problems with the red flag letters, right?
Oh, that's it.
Yeah.
That's it. But we have no red flag letters so far for Bari, I think.
That's true. That's true.
So that's an escape possibility.
Yeah.
And Hendrik, and how about you? What are you practicing?
Yeah, similar to what Rica says, and about 3 or 4 years ago, I was heavily opposing the idea of starting patients with JAK inhibitors simply because I thought not always is the newest thing the best thing, and why would we throw away all the other experiences with millions of individuals who have been treated with the different biologics. And in particular, there was no such trial as the upadacitinib trial showing that after failing a JAK inhibitor, the TNF inhibitor would be good. Now that we do have these data, we could actually use this as an argument. I'm a little hesitating in recommending this too early because of the red flag situation. But this is, as Rica said, I'll openly discuss this with the patients, and there's certainly some prioritizing oral medication, and then that's some, and we don't necessarily need the combination with methotrexate, which is also an argument for some of the JAK inhibitors. So that's something we usually openly discuss with the patient, and we're not prescribing, we are recommending. And if the patient says, I want this, we go with that.
Yeah, I mean, I guess the good thing is they are quite different classes of drugs. And so there's lots to discuss with the patient, as Rica and yourself says, whether they prefer oral, whether they want injections, whether they take methotrexate. So I think there's quite a lot of discussion to have.
Yeah.
We're running out of time, but we have got one final question in the Q&A, which I will put before we finish. It's from Massimo again. How about starting with a JAK inhibitor, bring the disease under control, and then switch to a biologic, which in principle may have less side effects and not the same red flags? What do you say to that?
Why not?
Hendrik?
I will probably do it the other way around.
Yes.
Going with target therapy to the TNF or IL-6, and then switch to something that has a more immunomodulatory mode of action rather than a complete difference, a complete blockage of one cytokine. At least there were some attempts to prevent or to combat flares of rheumatoid arthritis on patients on JAK inhibitors with a TNF inhibitor. But I think this question is wonderful. We should all do these studies, and we will see what comes out. Maybe another surprise, or maybe eventually something that gives us less headache and lots of happy patients. So it's a wonderful question.
Yeah, I think her philosophy is you'd spend less time on the JAK inhibitor, and if I can see that's nice. It's a nice idea. Rica, any thoughts on that?
Yes, no, I totally agree. Nothing to add.
Okay, great. Well, look, that was brilliant. Thank you both to Hendrik and to Rica, and to your questions. Very, very much appreciated. The live streamed version of this webinar is now available to view on the Cytokine Signaling Forum YouTube channel. Could I please ask you to fill in the short evaluation form? Let us know your feedback. Hope you've enjoyed this, but we'd need to know because that helps us for future events. And before I finish, please register for next month's Forum Live. You know, these come on every month, so it's a great way of keeping up to date and learning the latest. So again, thanks everybody to attending. Thanks to the Cytokine Signaling Forum for putting this on and for your continued engagement. So thank you, have a good evening, and see you all soon. Bye.
John, thank you.
Thank you, Hendrik.
Thank you so much.
Hope you feel better, Hendrik. Hope you feel better.
I'll go to my